Good afternoon, everyone. I'm Jeffrey Braithwaite. I'm Professor and Director of the Australian Institute of Health Innovation, if I don't know you. And also I'm the CIA on the Partnership Centre in Health System Sustainability. And if you're in research, you know what that means. It means Chief Investigator First Listed. That's what the A stands for. But if you're not in research, you think, here's some sinister guy from the US government about to do bad things to me. So that's not what's going to happen. We're going to do good things with you today. So we're going to simulate the health system and figure out whether we can, through the simulation, make it better. But that's running ahead of time. That's what will happen by 6 o'clock this evening. In the meantime, we've got a lot of stuff to get through to showcase some of the things we're doing in the Partnership Centre for Health System Sustainability. So what we're going to do is deal with this issue of treatment overload. So the people who carry, I guess, the burden of trying to coordinate all these people and many funding partners and all sorts of other people involved in trying to create a more sustainable health system are herded, led, corralled by Yvonne Zorinsky, who's just over here, who you'll meet shortly, and myself. So thank you, Yvonne, for bearing the burden of herding all the cats in this very large enterprise we call the Partnership Centre in Health System Sustainability. So welcome. So the buzz phrase, of course, is the world is a complex adaptive system. The health system, we hear that all the time, don't we? We hear people talking about the health system, and what they mean is it's this complex creature that's adaptive, it does change, but in interesting ways, not necessarily always because the policymaker or the guideline person says this is the way the health system should behave. It behaves in ways reflecting its complexity. Sometimes it does adverse things that we're trying for it not to do. Although the health system produces lots and lots of good care as well, as we know. That's because the systems that we are embedded in, that we are working on, that we are trying to improve, that we are trying to deliver care in, is the most complex system anybody's ever designed. No one's designed a human system more complex than healthcare. But that's the system that we want to try and improve and do what Paul suggests. Don't do too much medicine. Make it so that the quality of care is better in the long term. So, everyone's invited to join the Complexity Simulation Game. Of course, I'm using the word invite a bit generously. You're already in. You've dealt yourself in, or we've dealt you in. You are assigned to a group of stakeholders. You've already been assigned. You will see the sign on your table which tells you which group of stakeholders you are part of, and your task is to solve the problem I'm now going to give you. Here are the stakeholders. There's the Prime Minister's Office, the Treasury, the Minister of Health and the policy staff, the state health systems, the doctors, the nurses, allied health professionals, patients groups and their representatives, the media, and corporate interest. Francine, are you impressed that we did the media? We have the media here. So the problem. It's March 2020. Prime Minister Morrison has received a report from the Health Minister that 30% of Australian healthcare is low value, 10% is harm, and 60% is evidence-based. This, he says to the Minister, is a problem. Prime Minister Morrison says we need to solve this and to do more with less. We need the whole system to accept the 60-30-10 challenge. Some of my favourite people, nurses. Where is you up to in all this? Trying to solve this problem.
We're exploring the common themes behind 60-30-10.
One of the big issues is, because we also represent the representatives of patient groups, they are often advocates for more care, more money, more treatment, and for them to sort of advocate for less treatment, less money and healthier patients, you know, maybe there's a bit of a conflict there and they need to change their modus operandi. And then does prevention increase awareness and increase in overdiagnosis? So there's all these sort of things in the mix. So we didn't have any solutions necessarily, but education and awareness is probably the starting point.
She wants a legacy of better value in the health system, placing a well-informed consumer at the centre of the health system. And so it's about doing the right thing and making better value care easier to do for everyone.
Is this answering the question or trying to get re-elected?
So our first idea was a whole constitution change, and we want to, and we want to redesign it into a single funded system. But in case that doesn't happen, we have a plan B. So we were in line with the PM's office, and we talked a lot about value-based care, and we want to change that system into a value-based care. We wanted to invest it in primary care, so moving away from hospitals and focusing on primary care, reinvesting into workforce, particularly nursing, and then we also want to have a more integrated model of care which would reduce duplication and reduce unnecessary tests and procedures that would then save some more money to reinvest, and as part of that integrated care, really including consumers, patients, residents, and the family.
But investing in transparency is one of the things that we want to do, so that consumers can understand what's actually happening, not just consumers, but basically everyone. And that will also help identify the 30% of low value care and exactly where that harmful care is occurring. And then once we've identified that, investing in research, or specifically translational research, to fix some of those issues that are not policy levers that we have the policy staff for.
So the first two things we looked at were, one is what we call turning off the tap of the low value care by having better health technology assessment processes at the state level, mimicking what's happening with the PBAC and MSAC.
The PBAC and MSAC being?
Pharmaceutical benefits, which has a health technology assessment program. The drug's got to be effective first of all, and then it's got to have a good ratio of safety and be cost effective. Okay, similar thing has now been adopted for the MBS items through the MSAC, which is the Medicare Services Advisory Committee, which does a similar thing. There had been something apparently, I'm told, for the state systems, they're called Health Pact, but at the moment new procedures can be booked into new surgical procedures can be started in the hospital without any sort of technology assessment process.
So if I understood your original question, it was to comment on the process itself, and the process, as we've now, I guess, decided or discovered, was very siloed.
Yep.
The tables didn't really talk to each other, and in effect that's an analogy of the actual health system. If we can change the siloed methodology, then the funding methodology changes as well, because if you remove the redundancy, the complexity, the funding should then start to free up as well. So then what would you do? Well, let's try improving funding for outcome-based funding for doctors. So let's remove those perverse incentives that doctors can be attracted to. Let's make the system a little more transparent, and then let's have proper funding for the doctors and the services.
We should focus on what we know works in implementing change, which isn't necessarily more education. It's transparency of data. It's showing you what you're doing as a clinician. and how you compare to your peers, as much as that's possible, and using the tools that we know influence behaviour. Some of that's transparency, some of that's the culture, some of that's the patient voice. They're the things that will probably influence things more. Of course, there's barriers that have been mentioned by other groups. We need a system that can measure, have we made a difference? So we're planning change, but actually we need to know, is the outcome any different? And so we need a system that gives us the information so that when we make change, we can see if things are any different, whether it's the role of nursing or it's in advocacy roles or it's information for families and patients.
So we agree with lots of what's been said, but if I just cover what's different, I think we wanted to explain to the Prime Minister that health expenditure is just one side of the equation, and that we could also consider productivity returns from a healthy society. And so really they need to talk to their colleagues in Treasury about the cost savings from having less people on disability support payments or productivity returns from having a productive workforce. New models of care, you would fund it for an interim period of time, and if it's cost effective, you'd continue to fund it. If not, it would be withdrawn from funding.
Firstly, this kind of a challenge, you know, from the corporate perspective is an incredible opportunity for us to bring innovation, particularly kind of data and analytics techniques, behaviour change, big data, all of those kinds of things. It's a fantastic opportunity to use that to really harness the opportunities of big data, precision medicine, all of those things, to make sure that the care we're providing is ever more focused on what people need. And as a sector, clearly there would be great excitement about participating in a grand challenge in that way.
So we're going to have this TV series, War on Medical Waste, is going to tackle both people who, you know, the target for us are both those who have an interest in waste, and so we will have to do investigative journalists to put some transparency on that, who have interest in waste. And on the other hand, our target audience is also the people who are harmed by the waste, and so they are, you know, the patients and the general public, and so we will have to have kind of health literacy, empowerment and education part of the program.
One of the things is when you run something like this, it does imitate the health system, and it is true that people don't often go and see the patients, even though everyone speaks on behalf of the patients. They take that mantle on, and that's an intriguing thing when you run this. The other thing is problems like this are wicked problems. There's no obvious solution or even short-term or medium-term solution to trying to make the health system more evidence-based, less wasteful and less harmful. And we set you that deliberately so we could model how the health system copes with problems like this. One of the intriguing things is no one moved for 40 minutes, even though we didn't constrain anybody to their stakeholder groups. And that's a bit like the health system. People proceed from their stakeholder group, and the other stakeholders, they're the people over there that aren't us, they're defined by not being us. And that's a kind of problem, because these sort of problems can't be solved by any one group. And when you deal with problems only in your group, what tends to happen is your special interests shine through. Your biases and your own needs and interests become apparent. And you saw that as it unfolded. We still have to work in a complex system, so there's no escape. We're in the system, of the system, trying to improve the system, trying to deliver care in the system. And then finally, at the end of the day, you may not be able to change a complex system readily, but they do change. Systems do change. The system we've got now is much better than the system of 30 years ago. So there's no question that health systems change and improve over time, despite the complexity, the stakeholder inertia, all the things we've seen today. So there is hope, and I want to leave on that optimistic note. You can definitely nudge, influence, and shape health systems over time. There's just no linear magic wand type solution to these problems.